My name is Valentin Mocanu from the University of Alberta. Thank you for joining this talk. I have no conflicts to declare. I have received some suture supplies from Ethicon for murine surgeries, but this has not influenced my talk today. So with regards to our background, conflicting literature exists regarding the role of sex and race on outcomes following bariatric surgery. Males have been typically associated with increased rates of complications and weight recidivism, as they tend to be older and have more comorbidities at the time of bariatric surgeries. However, this isn't clear. Recent literature contradict these findings and suggest that rates of complications, readmissions, etc., may in fact be actually higher in female patients after adjusting for comorbidities. This contradictory evidence also exists with regards to race, as it's attributed also to different rates of remission of metabolic comorbidities and postoperative complications and mortality. So it's important to clarify the role of sex and race on bariatric surgical outcomes to address the current knowledge gap and identify a significant portion of potentially at-risk people who may benefit from additional peri and postoperative interventions. With that being said, our hypothesis was that race and sex do affect outcomes following bariatric surgery, and our aim was to characterize and examine the impact of these on bariatric surgical outcomes. To do this, we used a retrospective propensity-based analysis using the MBSAQIP database from 2015 to 2017. Our inclusion criteria was any elective Roux-en-Y gastric bypass patient or sleeve gastrectomy patient. We excluded revisional surgeries. Our primary outcomes were 30-day mortality and 30-day major complications, which is a composite outcome that we created based on a combination of leak, bleed, reintervention, reoperation rates, length of stay greater than 7 days, cardiac complications, renal complications, or thromboembolic complications. So to accomplish our goal, we created two propensity matched cohorts, the first being a male and female cohort, and the second being an African-American and a white cohort. We chose African-American racial status because it was the second most common racial status in the MBSAQIP database. To create our propensity matched cohorts, we randomly matched one-to-one patients using a 0.01 caliper distance. And this methodology limited over 99% of variation due to our baseline clinical differences. After our propensity matching, we obtained our first racial cohort. So this is after matching for major comorbidities such as age, female sex, BMI, functional status, ASA category, smoking status, diabetes, and other metabolic comorbidities. This can be seen in Table 1. So in total, in terms of our racial cohort, we allocated 74,924 patients to African-American and white racial status groups. The majority of clinical differences were corrected, but we still had statistically significant differences given a large sample size. So after matching, African-American patients were still younger, with an age of 42.7 years versus 42.1 years. They were less likely to be female, had a lower BMI, and had an increased operative length versus the white racial status cohort. When we examined serious complications between African-American and white racial status patients, using our propensity matched cohorts, we identified that serious complications were rare, but did occur in 3.7% of all patients, and mortality was also rare overall with a mortality rate of 0.1%. So after propensity matching, African-American patients did have higher rates of bleeds, acute kidney injuries, reoperation, reintervention, and readmission rates at 30 days. Notably, African-American patients also had higher rates of serious complications at 4.1% versus 3.1%, and more than double mortality of white patients, 0.13% versus 0.05%. We next examined propensity matching using our sex cohort. So in this cohort, we matched 86,296 male patients versus 86,296 female patients based on their comorbidities. Again, major clinical differences were corrected between the groups, but we still had, because of the large sample size, statistically significant differences between them. Female patients were older, 46.9 years versus 46.5 years, more likely to be white, of white racial status, 18.3% versus 12%, and had an increased BMI and higher rates of obstructive sleep apnea. Despite this, the majority of clinical baseline differences were actually corrected for by propensity matching. When we looked at complications for the sex cohort, the gender analysis revealed an overall serious complication rate of 3.7% and a mortality rate of 0.1%. After matching, female patients had higher rates of reintervention, readmission, and serious complications. Interestingly, though, we were able to identify that females had a lower mortality rate of 0.1% versus 0.2% in males. So taken together, we're able to identify that female patients had higher serious complication rates and lower mortality rates, and then African-American patients, in comparison to white patients, had higher mortality and higher serious complication rates. So when we originally submitted this, our reviewers weren't convinced regarding the findings, and they wanted a more robust multivariable logistic regression model. And this is what I'm showing here, just our model for mortality, which includes a number of comorbidities, but namely race, racial status, and female sex. And what I want to draw your attention here is that after matching for major comorbidities and looking at a mortality following bariatric surgery, female sex was found to be the single greatest independent protective factor for mortality. And Black racial status was interestingly found to be the single greatest independent predictor, single greatest non-modifiable independent predictor of mortality following bariatric surgery. So what does this mean? Taken together, we identify a particularly at-risk group of African Americans, which independently have adverse outcomes following bariatric surgery and nearly twofold the odds of dying postoperatively. We also further identify that female sex is an independent predictor of major postoperative complications. Our study did have a number of limitations, namely it was retrospective, and the propensity match methodology is subject to limitations with regards to inability to completely match cohorts for major comorbidities. We have addressed this with our multivariable logistic regression model, however. The MBSAQIP database also lacks more nuanced data regarding patient comorbidities, surgeon data, and patient-specific data. Of importance, particularly with regards to sex-specific difference, the database doesn't collect information on things specifically with regards to sex-based pathology like polycystic ovarian syndrome, and this may confound our findings. Also, the database also does not collect information on medications or socioeconomic status, both which are major factors which can also confound our data. So to conclude, African American patients and female patients make up over 80% of all MBSAQIP bariatric cases. And this is important because they're both associated with significant adverse outcomes following bariatric surgery. We've clarified this with regards to the knowledge gap in contrast to prior literature, and we've identified that further work needs to be done to understand the influence of these factors if we hope to continue optimizing outcomes following bariatric surgery. Thank you very much.